All right, welcome everyone. Panel tonight on the healthcare reform laws and the impact locally and across the states, or New England, I should say. I'm the director of the Healthcare Administration program here at Marlborough College Graduate School. My name is Ariane Krumholtz, and I want to introduce Craig Miskovich. He and I had talked about doing a panel for several months now, and there's a lot to be learned. There's a lot of uncertainty, obviously, in what lies ahead. So we thought it would be worthwhile having an open forum and including our own students in the master's program as well. And by the way, I welcome any inquiries about our healthcare administration program. Craig Miskovich is an attorney with Downs Racklin Martin, which has an office right here in this building, but it's across the country and international as well, right?
We do work, most of our offices are in Vermont. We have an office in New Hampshire as well, but most of our work is in the New England region, although we do have specialty practices, including our health practice, that will practice nationally.
And because Craig specializes in healthcare, he also is the director and chair of the health law group at DRM, and he instructs our legal issues course for the healthcare administration program here. So I want to welcome Craig and our illustrious panel here, and I'll hand it over to you.
Great, thank you very much, Ariane. I've warned the panelists that they're going to have a hard time getting a word in edgewise. I have a lavalier mic and a presentation, so I may have mislabeled this as a panel discussion. But I am sure that they will learn that they will have plenty of opportunity to speak to correct the errors in my presentation. Let me first say that it is a wonderful time to be a health lawyer in Vermont, New Hampshire. It is no exaggeration to say that health lawyers these days walk around like rock stars, that everybody wants to know what's going on with healthcare nationally, what's going on with healthcare more locally, what's the Supreme Court decision. How's Justice Kennedy going to go on that vote? Is it going to be 6-3? When's the decision? All wonderful stuff, and we'll probably talk about a lot of it today. But as good as it is to be a health lawyer, it is probably even better to be one of these three esteemed gentlemen. Because what a great opportunity to operate and to manage a healthcare institution than in the middle of the maelstrom that is national and state healthcare reform. So we have an incredible panel. I mean, really, no exaggeration. We have great folks who have great experience, who represent great hospitals, and will represent a real gamut of healthcare reform. We have a couple of acute care hospitals, one in Vermont, one in New Hampshire. So I'm hoping that we'll have a discussion about the differences, the expected different treatment for those two facilities. We have a psychiatric hospital in Vermont, so we're going to have an opportunity to compare physical health and mental health treatment under federal and state health reform. So we have a great opportunity to start to think about some of the ways that administrators are going to be challenged to implement state and federal healthcare reform. So first, our first panelist is Steve Gordon. Steve's the president and CEO of BMH, was the president of Good Samaritan Medical Center in Brockton, was the chief administrative officer at Children's Hospital, Steve and I have an acquaintance in common. One of my best friends is a pediatric transplant surgeon at Children's. And if I could do math in my head and could do the years of residency that it would take, I think there's no greater job than being a pediatric surgeon, transplant surgeon at Children's Hospital. Don Crusoe is the Chief Medical Officer at Dartmouth-Hitchcock-Keene, and also an opportunity to talk about the relationship between Cheshire Medical Center and Dartmouth-Hitchcock-Keene, which is an affiliation that is, not the kind of affiliation that we often see in the Vermont system, but in the New Hampshire system it's more prevalent. And Don is was the is, I should say, a physician, has been a physician practicing in family medicine, family practice, over in the area, Keene area. Was the chair of the Department of Family Medicine and was the 2003 Microsoft Physician of the Year. Which begs the question, what have you done lately, Don? Right. Yeah, just 9 years ago. And then finally, Rob Simpson, President and CEO of the Brattleboro Retreat, formerly the CEO of Arbor Hospital and the Chief Operating Officer of Behavioral Healthcare in Massachusetts. So thank you. I really appreciate your participation, and I look forward to tonight. Okay. Healthcare payment reform. So we're really going to focus on payment reform today. And I give this presentation in various forms quite often. And in most often, recently, I've been giving this presentation to chambers of commerce and employer groups. And we'll talk about the health benefit exchange and some of the incentives that are built into health benefit exchanges and what the state and federal reform effort might mean to those folks. And so I think we'll keep the theme of incentives going, but we're really going to change our focus to incentives for hospitals and incentives for providers. And so that's our focus now. We're happy to talk about, patient care issues and employer issues and employee issues and all of that. But really, I think the panel would be able to provide the greatest amount of information about payment reform efforts and how they'll affect hospitals and administrators. So what's the problem? What's the problem? Well, and Richard, you've seen this. I don't know. How many times have you seen this slide, Richard? This is, you've seen this 50 times, I imagine. I've stolen this from the Director of Healthcare Reform for the state of Vermont and a few other slides as well. And I'll bash on hospitals for a while. Our hospitals spend too much, or maybe we spend too much at hospitals, but whichever way you want to look at it, we spend too much in America on our health care, both as a per capita basis and as a percentage of GDP. And the numbers are pretty stark and getting starker, if that's a word. And we also push too much of our burden for health care onto our employers. Right? And I don't know if you guys, if you're wonky like me, you saw that the House Ways and Means Committee came out and was very critical of the Obamacare, the PACA, Affordable Care Act, and the exchanges, because it was going to mean that many of the Fortune 500 companies in America were no longer going to provide health insurance to their employees. They were going to reduce that expenditure from their balance sheets, and the employees were going to buy their health insurance on the individual market. I thought that was odd that the House Ways and Means, that the Republican committee would say that the reason Obamacare is bad is that it saves employers money because they're not going to provide health insurance anymore. Because employers spend a lot of money on health insurance right now. Now, my economics professor would say, no, the employers may pay that, but the cost is really a cost to the employee. That my salary from Downs Rockwin Martin isn't the amount of money that I take home every week. It's the amount of money I take home every week plus the amount of money that my employer had to pay for all the health insurance that I get. So this is lost wage opportunity for employees, and it is a direct cost to employers. And in 2019, the expectation is $28,530 per employee. That's pretty close to the average median wage in the state of Vermont, probably the state of New Hampshire as well. And so, as a percentage of GDP, Vermont is worse than the national average. National average in 2009 was 17.6. We Vermonters paid 18.5% of our GDP for health expenditures. And New Hampshire, it's a little harder to read, but New Hampshire is is, and I'm from Vermont, so I can say this, it's always worse than Vermont. New Hampshire, in this case, is worse. It's 20% of GDP in 2009 as well. It's a little hard to read, but take my word for it. About 20% of GDP goes to our health expenditures. Okay. And this is just one slide. There's lots and lots of them, and I'm about to stop bashing on hospitals, but we don't get the outcomes we want either. And that's the general consensus. These are really all kind of accepted facts and wisdom now, right? Here's us in the U.S. and especially with our chronic disease care, we don't do as well as really anyone, and we have bad health outcomes, even though we spend a lot of money. But we know that. Okay, so I want to talk about incentives, and this is where I want to really engage the panel. I want to talk about how we pay for care and what the incentives are for the care. And if we were trying to have a global understanding of all payer sources, I couldn't do that. It would make my head spin. And I think that it wouldn't be a very good conversation either. So I'm hoping that we can really limit the conversation, at least in the initial part, to Medicare. It's a very big program. It drives all of the federal regulation regarding payment. It is the vehicle for all of the federal payment reform efforts. So let's just kind of have a sense right now of how Medicare compensates providers for the care it provides to covered individuals. And so you all probably know this, but so you have Part A, it's your inpatient care. And that's going to be made under the inpatient prospective payment system. We'll talk a little bit about that. That's your hospital payment. That's the amount that Medicare is going to pay to the hospital for the hospital care for inpatient care. Part B, that's your physician services. Those payments are made on an entirely different schedule. And those are on the a fee-for-service schedule. So very different incentives already between Part A and Part B. How am I doing, Mike? You got that so far? Yeah. Okay, good. Part C, Medicare Advantage. This is interesting. There's a Medicare program, but now it's going to allow some risk-sharing organization to issue health plans and have somebody in the system who bears the economic risk. Now, right, who's bearing some of the economic risk up here in the hospitals when they have an inpatient payment? Well, kind of the hospital is, because they got to make sure they can deliver that care. Who's bearing the risk on the fee-for-service? Well, not the doc, because the doc's just going to get paid for the service. And so it's probably the payor that kind of bears the utilization risk there. See, the Medicare Advantage, now you have some risk sharing going on. And then Part D, I don't understand, so we'll move on. Because it's beyond me. Okay. All right, so here's how hospitals get paid. The hospitals get paid under the, again, IPPS, the Inpatient Prospective Payment System. All patient illnesses and injuries are classified into diagnostic-related groups, or diagnosis-related groups. This might be a good place. How much time and effort do you guys and your staff spend on billing under the DRG system? Is that an easy and fluid billing process for you?
No.
That's a softball. Elaborate, Dr. Simpson.
Well, if you take psychiatry, patients who are admitted on DRGs related to psychiatry, let's say psychosis, there's an average payment that Medicare gives. And if you're a finance guy, you're looking at, okay, what's the average optimized payment I can get? All right, let's say it's after about 9 days for psychosis. All right, so at 9 days, everybody should be discharged according to the CFO, right, Mike?
Absolutely.
9 days, they're gone. They're gone. Better or not, whether anybody wants them, 9 days, that's the maximum payment, let them go. Because after that, what starts to happen? Doo-doo, 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 goes down. So the incentive is, really, on the hospital side, get the patient out after 9 days. Let's just pick that number. And for another diagnostic-related group, major depression, bipolar disease, it may be 8, 7, 6, whatever the number is, So the finance guys are always going like, here's the report, you know, Dr. Jones, he's keeping people too long, you got to move them out. Of course, Dr. Jones often has nothing to do with whether a patient can get out, because it depends on the downstream system that's in place or in Vermont not in place. Is there a place to send them? Is there a residential program that will take them? Is there a community that wants them? Is there a residential site that hasn't been NIMBY'd out? It's a problem to sometimes get patients out when they have a psychiatric illness related to stigma, et cetera, et cetera, et cetera. So that is part of the problem with the DRG system in psychiatry. The incentive is to move them out on a payment basis, but there's often no place to go.
Right. And so Rob just kind of highlighted my last bullet point, in that psychiatric hospitals have a per diem PPS. But critical access or acute care hospitals have a per diagnosis, per admission PPS. Yes, the PPS hospitals.
I think it's important, especially in Vermont, half the hospitals in Vermont are called critical access hospitals. These are hospitals that have 25 beds or less. They're not paid under a DRG basis. They're paid as a cost plus, like the good old days of Medicare, where you get paid your cost plus a little bit for investment purposes.
Mm-hmm.
The PPS hospital, the non-critical access hospitals like ourselves at Brattleboro, are fully at risk. So that we get one payment for that DRG, regardless of how long that patient stays in the hospital. Now, we've gotten pretty adept at coding for that stay. So we capture comorbidities with the patient, other situations, to make sure that we get reimbursed as appropriate for the care that's been rendered to that patient. But we are at risk, as opposed to other hospitals within the state of Vermont. So it's really not a level playing field from how we're paid by the federal government. But, you know, we've been doing this for a long time. I figure out when DRGs came in. 80s?
October 1, 1984.
Thank you. I'm glad the CFO Brattleboro Memorial is in the audience. You know, making sure that I don't say anything that is incorrect.
I'm taking notes, man.
So, you know, and we just did a little analysis that Mike provided me. Medicare is paying us about 70% of our costs. Medicaid is about 31% of our costs. How do you live with that? Well, that's the future of what we're going to be faced with, I think, at least as hospitals, is how do we live with Medicare payments alone? So that's why we've got to be as efficient as possible in delivery of our care.
A couple, yeah, Don.
One of the other things that just drive this approach is that, and I'm sure in both of their institutions it's the same thing, we hire highly paid RNs to help us manage people out of the hospital. So this is not value added in terms of patient care. So we have an RN who looks at the chart every day, who nags me as the physician saying, Mrs. Smith needs to go home, and you're saying they can't go home. For medical side, no different than the psychiatric side, maybe a little tougher on the psychiatric side. But again, we're paying people, highly paid people, dollars that really don't add value to the outcome.
Rob, you mentioned that finding a suitable step-down facility is a challenge. CMS doesn't cut you a break. They don't say, well, you don't have any appropriate step-down facility, so we're going to continue to pay you your costs. That's only fair.
No. Go work on that, though.
And for the hospital, the acute care hospitals, too, because we're fully at risk. That's it.
And back to kind of incorporating Don's comment from earlier. So now, because there's no appropriate kind of step-down facility, you end up having care that costs more than you're getting paid, and it's in a setting that's not appropriate for that patient at that time. Right? You'd want to discharge the patient to a lower level of care.
Right.
Yeah.
Exactly. And I'm not saying all Medicare patients fall into that. They don't. There's some Medicare patients that are employable, have jobs, communities, go back home, and everything is fine. But that, you know, for patients who have chronic mental illness, severe persistent mental illness, that's not necessarily the case. Now, all states have worked to create appropriate step-down facilities, but it's just the question is how robust is that process? In Vermont, with the new state law, Act 79, we're trying to put more money in the step-down services so we can actually reduce the hospitalization days and costs and get people into the community earlier, which I think is great. I support that. In the meantime, there's also a cost shift, which the three of us are quite familiar with. If you can't get it out of Medicaid or Medicare, you're going to get it out of your private pays. So you're going to work hard on contracts, and Mike is a great driver in contracts. Ariane used to drive contracts in the Bayside Health System. You really push to get 107% of cost, 112% of cost, 120%, so you can make up the loss you're getting elsewhere.
So wait. I'm paying more for my health care than it costs?
Yes.
Well, that's not fair.
No. Well, yes, it is to us.
Oh. And Steve, I'm a P&L kind of guy, and you're a P&L kind of guy. You said something that triggered, or I perked my ears, and that is that there are competitors in the marketplace, or that might be my expression, but that you have hospitals on which you have a competitive disadvantage because of the way you get paid.
From an economic standpoint,
right?
Yes, absolutely.
Yeah.
And because we're not a critical access hospital, Cheshire is not a critical access hospital, and as a matter of fact, one of the things we've been talking about with Cheshire is we're called Medicare Dependent Hospital, MDH. And Medicare Dependent Hospitals are those hospitals that have 60% or more of their patients covered under Medicare. And because Medicare acknowledges that they don't pay the full cost of the care, they give us a little something extra. In Brattleboro, it's about $1.5 million. I think you're about double that. Bennington is probably about $3 million. That program goes away October 1. It's gone.
And that's different than the DSH payment, the disproportionate share hospital payment, which you still get, but Don doesn't get anymore.
So, we're going through a budget process right now at $1.5 million has just gone from our revenue lines.
Yeah.
So we're all faced with that at this point in time. So there's no rabbits to be pulled out of the hat in terms of improving our standing with Medicare or anybody else to make up for that difference in terms of payment compared to the critical access hospitals.
I'm going to go on to the next slide, but thank you very much. Just want to point out, and this is, the source of this information is from CMS itself. So, and Steve had mentioned it earlier, that the inpatient prospective payment system replaced the reasonable cost method, where hospitals just got paid the cost of providing care. When that happened, people respond to incentives. Hospitals respond to incentives, physicians, attorneys, everyone responds to incentives. And there was a reduction in the average length of stay for hospital Medicare beneficiaries. But there was also an increase in the number of same-day surgical procedures in hospital outpatient departments and ASCs, or ambulatory surgery centers. And that ambulatory surgery center in Vermont is not that's not a common provider. But Burlington has a few. Just one.
Eye surgery center.
Yeah, Singer Eye Center up there. And New Hampshire, is that a
Fairly common.
Yeah, more common in New Hampshire. Yeah, and this is another great contrast between the Vermont and the New Hampshire system, is that the Vermont healthcare delivery system, at least at the hospital level, is exclusively nonprofit, really community nonprofits. There are 14 hospitals in the state of Vermont, Fletcher Allen being about the same size as the other 13 combined. No exaggeration. Each one of those is a nonprofit hospital. And then within the hospitals, they have different delivery cares and different delivery care models and different relationships to their physicians. But at the hospital level, at least, it's nonprofit. New Hampshire has a more varied hospital structure. Yeah.
Population density is much higher in New Hampshire than Vermont.
Yeah, right. I mean, Vermont is 600,000 lives. One of our insurers, Blue Cross Blue Shield, has half of those, 300,000 insured lives. And that's a big suburb.
But having been a CEO at hospitals in both New Hampshire and Vermont, Vermont is a much highly regulated state as opposed to New Hampshire and live free or die.
Live free and die,
That doesn't
I think.
equate to higher reimbursements. But from a regulatory standpoint, our budgets have to be reviewed now by the Green Mountain Care Board before VISCA. Anything over $1 million, such as a CT scanner or something like that, you have to get approval by the state.
Yeah.
It's a much more highly regulated industry in Vermont.
And we're entering into the first budget cycle with the Green Mountain Care Board being with the review board. And my sense, and you guys don't need to comment if you don't want, my sense is that that board is going to be far more aggressive than VISCA was historically, and that the board is going to look at the budget process almost as a little CON process, that individual line items on the budget, individual pieces of equipment that might not rise to the CON threshold, will be scrutinized and approved or maybe denied through the budget process. And I think that's a
Probably accurate.
yeah. I'm sorry to not seek out the comments from the audience either, but if you have any questions or comments, make sure to interrupt me. So how do physicians get paid? Well, physicians have it so easy. This is the gravy train. They just get paid to do stuff, which is also how lawyers get paid, so I don't want to be too critical of physicians, right? I think some professions should have fee-for-service. No capitated payment for lawyers. Let's not get crazy here.
No fee schedule.
Yeah, no fee schedule either. Good point. So physicians are paid national fee schedule. And they get paid for the stuff they do, and they get paid for the stuff that happens incident to the stuff they do, and they get paid for the stuff they order to be done. And so this is, when people rail against the fee for service, they're really railing against the way physicians get paid under the national fee schedule. And they're railing against the incentives that this kind of system implements and creates. How many of you guys employ your docs?
We do.
Yeah.
Oh, Brattleboro's, you know, we've experienced this in the last 2 years as a lot of the docs who came to Brattleboro in the 70s and 80s are now retiring, moving out of practice, that the only way to recruit new physicians into the market, which we need, are through an employment model. So we now employ probably about 35 physicians, and we employ the nurse midwives. And it's not just primary care, it's OBGYN, it's our general surgeons. And that is a situation that's really occurred in just the last 2 to 3 years. And what, so we're significantly behind in terms of Dartmouth-Hitchcock Clinic, which has always, existed as a strong physician-based model. So what that means is for our hospital, is I don't look at it at just us being a hospital, it's really creating a microcosm of a healthcare delivery system, involving the physicians, involving the hospital, involving our outpatient services. And we've had to build a significant infrastructure, which has probably taken us over $1 million to do that, for an electronic medical record in the physician offices, for practice management, for centralized billing and scheduling. It's been a huge investment on the hospital. When people think the hospital, they don't really think it's also the medical staff. And I would assume that probably over the next, certainly in the next 2 or 3 years, probably 90% of the docs will end up being employed. And Brattleboro is actually behind in terms of where other hospitals have been, certainly in New Hampshire and in other parts of Vermont as well. And Massachusetts has a very high penetration of employed physicians. And that's a big difference than what it was, I'm sure, when you came out.
So yeah, about 9 years ago, Cheshire Medical Center decided that rather than be competitive with, at that time was Keene Clinic, not Dartmouth-Hitchcock yet, said, we see things going differently, and rather than spending our money to hire physicians, we want to partner. And so 9 years ago, Cheshire Medical Center and Dartmouth-Hitchcock created a joint operating agreement. So there's a shared bottom line at this point between the medical center and the physician group practice. It's still an open physician practice in the hospital, so anybody can come to Cheshire Medical Center. I can tell you probably about 5 years ago, we couldn't hire physicians into the multi-specialty group practice. Docs wanted to stay in private practice. Now, every day we get people asking, docs asking, do you have a need? I have people calling me for pediatric rheumatology where there's absolutely no need. I mean, that kind of demand for being in a group practice now. And a lot of it is economic.
And why do they want to come out of the cold?
Big part, well, when we talk to primary care guys, a lot of it really has to do with economics. So for primary care, really not financially viable in terms of new primary care docs coming out of training, probably somewhere around 400 grand in loans, and then trying to figure out how to get paid enough to cover those loans. And then the docs who are out in practice, even the specialty guys saying, you know, yeah, maybe the economics aren't that bad, but we think they're going to get worse. And oh, by the way, all of the pieces around running this practice are just way too time-consuming.
Yeah.
That's not why I went to medical school, and it's gotten very, very onerous to really run that practice administratively.
A small group can't afford to bring in an electronic medical record.
And they're going to start to get dinged on their Medicare reimbursement because they're not going to meet their meaningful use criteria for their electronic health records, medical records. Don, you said that it's not economically feasible for some practices, some groups, and especially new docs to be in private practice. Is it economically feasible for you to hire them, or to have Cheshire or Dartmouth Hitchcock Keene, or is there a kind of a cost shift going on even amongst practices? Do you have loss leader practices?
Yeah, and so there really is cost shifting that occurs within the medical group, and there's cost shifting in our arrangement between Cheshire Medical Center and Dartmouth Hitchcock Keene, because you put up there the X-rays and radiation therapy, and those still live typically within the hospital structure, and they're still highly reimbursed. And so in a sense, some of that money, that reimbursement really flows into the physician group practices, because who orders those tests are the physicians. Now there's a lot of stark regulation, a lot of legal pieces around ways that can't get actually done, but there are ways that you can actually say the physician is part of the group practice, they get paid a certain sum of money, and we flow the money within the multi-specialty group practice, because essentially it doesn't matter if you're a family doc in Keene, DHK, or you're a family doc who works in the city of Keene, the reimbursement's exactly the same. So orthopedics still highly reimbursed. Money flows from those orthopedic practices into primary care because it's part of the mission of the organization.
Yeah. Okay, so if that's how the world worked yesterday, here's how the world might work soon. So these are the federal payment reform efforts inside of Medicare. Again, that's where most of the federal payment reform lives. It's the largest program, and it's a good opportunity to try these particular care improvements. No one here is participating in a bundled payment for care improvement program, are you?
We looked at it with the state of Vermont and the Green Mountain Care Board as they're looking at payment reform, and this was one of the areas. But you've got to have a substantial volume of orthopedic cases, total knees and hips. You can't do bundled payments for a smaller number, and that's why we at Brattleboro, it was not going to be feasible for us to do that. And quite frankly, other than maybe bigger hospital like Rutland or Fletcher Allen, I don't think there are many hospitals that, at least in this state, that can look at doing something along the bundled payments, because we just don't have the volume. They're, in general, very small hospitals.
Yeah. Anyone in New Hampshire doing this stuff?
We have the exact same issue. Dartmouth is doing it. Big Dartmouth is doing this. They have enough cases. We look at it for orthopedics, which is probably the only real viable one, but we don't do enough cases either.
Yeah. So let me explain a little bit about what these bundled payments are. So instead of going and being paid as you would under Medicare, as I described earlier, you take all of the providers who touch a particular patient for a particular surgical procedure, say, and then you give them one big lump of money. And the hope is that that big lump of money that you give them as a bundled payment that they get to share and fight over and allocate amongst the providers is less than if you'd given every single person their payment under either the fee-for-service or IPPS program. And some models will allow gain sharing. So if there's a reduction in the amount, then that participant gets to share in the reduction compared to what would have been paid by Medicare if they had done it piecemeal. Another federal payment reform effort that's occurring is the Pioneer Accountable Care Organizations. And I don't know much about these, but Don knows a lot about these. And Big Dartmouth, as you said, and Cheshire Medical Center as well?
This is a partnership with Dartmouth-Hitchcock.
Yeah.
It in a sense is associated and affiliated. It's not an ACO. Dartmouth-Hitchcock is the ACO.
Okay. They are an accountable care organization. And this is going to, the idea is that it is going to change the incentives dramatically. And so at the end of this program, you may have an organization that gets paid on a population-based model. So they get paid money. I think in the first 2 years, there's kind of a shared savings. Medicare says if this type of treatment would have cost $1 million, but you were able to do it for $800,000, so you know what? We'll split the pot. You get 100, we keep 100. That kind of shared savings in the system. But then if you have a hospital that wants to bear that economic risk, and this is a lot of economic risk, and it's hard to imagine hospitals without substantial resources and really good payment histories and understanding of their patients to doing it. You have to have a lot of data. And they say, you know what, bring it on. Bring on everybody in the community. We'll take all comers, and you just give us a fee for doing that based on a per-person fee. How's it working?
So we have yet to see what the actual financial outcome is.
Yeah.
So the first year really has to do with preparing. Right now we know we're in a volume. We need to move from this volume-based system, where we are right now, into this value-based system, which is a very big change in terms of how we actually provide care. So when you go in and you have that orthopedic surgery, we want to make sure that it's done as efficiently and as effectively as possible, meaning you still want your length to stay down, but we also want to make sure you don't have complications because we don't want you readmitted, and we want to make sure that you go home with the best care. And if that best care is seeing the cardiologist and having visiting nurse, those things happen, so you think that costs more money. But the reality is you want to keep down the hospital admission, readmission, and emergency room visits. That's really what accountable care is really, in a sense, financially all about. So you have to have data to know who are those people that really are going to need those interventions, what's the right intervention, because it's evidence-based care now. It's also about value rather than all about dollars. And because what we want to do is say, it costs less and our outcomes are better because we also get paid based on quality. So to actually get the savings, you have to hit your quality benchmarks. You hit the quality benchmarks, you actually can save money for the federal government, and you're sharing that. Our goal really is to get to that population-based model where we actually get a global payment, because we think we can provide the best possible care, because we think we have enough data, and we think we have really good processes in place. It's a very different system. Our goal is no longer how many times can you come into the doctor's office to keep the doctor's schedule full. It's really, you need to come in because this is the right care, and oh, by the way, the right care actually, when you went back to that original slide in terms of outcomes, provides better outcomes. And that's the concepts behind it. So how's it working? We don't know yet. We've actually just received our first set of data from CMS. CMS promised us, typical government promised us somewhere around April or in June. We just received the first set of data, and we're in the process of looking at the data to see where we are.
And are you bearing risk in the first year?
Yeah, in the first 2 years, you actually have to put money in a bank account that says if you hit that 2% threshold, you have money to pay the federal government back.
What's the 2% threshold?
Somewhere around $20 million.
No, what does that mean? The 2%.
So what happens is that if we don't.
And 2% of any number that's $20 million is a really big number.
Yeah, and essentially it's what Medicare pays the Dartmouth-Hitchcock organization.
Wow.
For their, it's really what we expect to get back from CMS. So really what happens is that if there's a corridor. Okay, so the federal government says that if you get above 2% savings, we're going to give you some money. Okay? We'll give you the first dollar of that 2%. Okay? If you fall below 2%, meaning it costs you more money to take care of that patient, 2% more than the national average, you have to pay us back the first dollar. So we really want to stay outside, above that. Obviously, we want to stay above that, but we don't want to fall below 2% or cost more than 2% of what it is nationally. So
Wow.
that's the upside and downside. So it's basically.
And that's in the
two-sided.
first year.
Right, that's in the first year, and that's Pioneer, different than the other shared savings models.
Yeah.
A lot of those just have upside risk.
Yeah, but less upside risk than you could possibly get if you went all the way to a population-based model.
Right. The piece of Pioneer is that there's more value in terms of finances if you actually do the things you're supposed to do.
Yeah.
And that was really why we joined, because we really said we think we can do this.
Now, I doubt that any of you are old enough to have been around for HMOs in the 80s. But how is this different than an HMO? I mean, isn't that, I wasn't an HMO. Isn't that an HMO? Somebody bears the economic risk, and they try to manage my utilization to the cost that they're getting from their payment sources.
Hey, devil's in the details.
Yeah.
Because you are going to get, I mean, you know, I worked for Tufts Health Plan for 9 months. It was the worst 9 months of my life. But, in New Hampshire, and I ran Tufts Health Plan for the providers in New Hampshire. You know, no one could understand how the HMOs came up with their budget numbers to pay the providers. You know, it was this black box, and no one really understood it. And it was all about driving down utilization. And after the first 2 years, you've driven down the utilization, and what's left? That's a really big problem, is we look at now going to population base, because as the population gets older, there's going to be demands for more care.
Yeah.
And in Vermont, especially being the second oldest state in the Union, that has me very concerned. In Brattleboro, which is in Windsor County, Windham County, which is the oldest county in Vermont. We get 2 strikes against us already, as we look at going to more population-based models. But I think, you know, I think there are similarities, but there are dissimilarities. But the proof's in the pudding as to how the government's going to roll this thing out.
Rob.
So if I can go back to a prior stage in my career in the 1990s at Bay State Health System down south, when the Bay State system was looking to get capitated health care payments from major payers, including Medicaid and partners in Boston. There was a process to set up systems to manage that. And you remember medical management with Kevin Benjamin and I. So I was partnered as the site guy with the chief internal medicine person to look at how we could create medical management tools to help manage capitated payments. So, and then in this situation, the brain becomes very important. In a fee-for-service world, the brain is just paid on a fee-for-service as an organ that gets sick, episodic care. So, but in a world of capitated payments, where 40% of behavior potentially drives healthcare utilization, suddenly the brain becomes a very important organ that everybody wants to find a way to get. How do the primary care docs and how the rest of us make sure that we are treating untreated depression and mental illness, which is also driving medical illnesses? So suddenly we had a role to play in a larger healthcare system. As soon as capitation or bundle payments go away, we just retreat down into the lower echelons of the payment world, and it's those people over there that maybe we don't need anymore. I remember, I said to Mark Tolosky in 1995, he said to me, Rob, behavioral health service doesn't make any money. I said, but it could save money in the capitated arena. He said, yes, but the incentives won't be aligned anymore. We're just dropping all our caps. And I said, but someday we'll come back and we should be ready. And he said, someday. So maybe someday's coming back.
It strikes me that if Steve becomes an ACO, he's going to be working with you quite a bit, right? I mean,
well, I think the difference, going back to your original question, what's the difference between now and the future and where we were with the HMOs? It's going back to population base. You're taking large populations and looking, and you need big numbers. Brattleboro, we can't do it. Our service area is probably about 45,000 people. That's why we as well as other Vermont hospitals are talking to Dartmouth-Hitchcock Medical Center about being part and parcel of a larger entity for serving as the Vermont ACO component. Because none of us alone will survive if we have to manage the care, because it's such a paradigm shift in terms of how we think about getting paid or reimbursements. And our management systems are not based upon prevention, they're based upon illness. So it's a big shift in how we're thinking. We don't have the tools.
In small populations, there's too much potential variation toward escalation of cost, and 2 or 3 single cases can blow your whole budget right out of the water. You need to have millions of people in the bucket.
Yeah.
There's also 2 other things though, that are very different. So one of them is that, and one of the reasons that managed care was so unpalatable, it really had to do with patient choice. And a big piece of Pioneer ACO, but shared savings models, is that patients still have choice. They can choose their PCP, they can choose to go anywhere. So that ability is really critical. The other piece is that there really was no quality intervention that was paid. There was really no value. It was all about utilization, and it really wasn't about how do you get the best care. And so that really starts to drive a very different value-based approach than really where managed care was back in the 80s.
You mentioned that you just got the data. Does that data include your patient satisfaction and your quality?
Patient satisfaction is a portion that's mandatory within Pioneer ACO.
Yeah.
So we won't see that because the federal government won't implement it. And the federal government is, we actually have done it in Dartmouth for many years for ourselves, so we kind of know where we are with that.
Yeah.
The federal government has basically mandated a certain company to do this in the first year. We'll see that data in October.
Any anecdotal evidence? How are things going?
You know, one of the things is that we actually had to do, because with the Pioneer ACO, it's highly regulated in terms of what the federal government will allow us and not allow us to do. Any type of messaging to patients requires federal government approval. So if we do any kind of marketing, they have to look at the marketing material. What the initial letters that went out to the patients telling them that they were going to be part of a Pioneer ACO if they chose, and the question that was asked of those patients was, will you share that data, okay, with your physician? Pretty clear. About 3% of the patients responded, and they were more basically saying, no, the federal government can't have my data. The federal government already has the data. But in fact, there was really no pushback in terms of the concept of ACO and really how it applied to their care. So that's the only anecdotal stuff we have so far.
So what do you guys have to change in order to move from a fee-for-service world or an IPPS world, or the world you're in now, to a world in which, you know, maybe individually or collaboratively, you're getting paid on some sort of capitated basis?
And
sure.
One example, it's going to be idiosyncratic to psych, but if you're in a general medical hospital or a tertiary care environment, like Bay State Health System in the 90s, we did a study. We looked at what % of patients in those hospital beds for other diseases, cancer, cardiac problems, etc. What % of their illness was driven by depression or addiction? And 25 to 40% of their illnesses were driven by those problems. The fee-for-service system would say, treat the medical problem, transfer and refer on to the psych unit or the detox post. In a bundled care system, you'd be having consultation liaison psychiatry in there immediately, assessing the disease burden of the psychiatric and addiction issues, and how they could be mediated to drop the payment and care of the chronic medical institution. That would change. So the psych people become compliance related to getting patients to be compliant to the care. They can follow their medical regime. Patients who have depression and illness are non-compliant to medical problems post-hospitalization.
Yeah. I gave a presentation at I'll fall on my own sword here. I gave a presentation at VAS a few years ago in which I talked about WRVUs. And this is the way to incent your physicians to work harder, because your physicians who come in from the cold, they also come in and they start to act not like the entrepreneur that they were when they were out in their private practice. They start to act like me as an employee. And my productivity goes down when I'm not the entrepreneur. So I said, you know what? Let's have all our docs get paid on a WRVU basis. And I imagine if you're a hospital and you have a bunch of long-term contracts with your docs, and you're paying them on how much stuff they churn, and you want them to stop churning stuff, that's a cultural shift for the entire medical staff.
But it goes back to what Dr. Caruso was saying. It's all about quality. And that's the difference between the new population-based model as opposed to the old model of HMOs, which was really based solely on utilization and driving down utilization. I think what's going to happen in this state
because we're a small state, is you're probably going to have 2 ACOs potentially developed. One around the Dartmouth-Hitchcock sphere, because a number of us use Dartmouth-Hitchcock as a tertiary referral source. So, you know, whether it's ourselves or Springfield, Mount Scottney, Bennington now is moving towards Dartmouth-Hitchcock. We have a southern tier of hospitals around that sphere, and then Fletcher Allen, you know, which is 2.5 hours away, having other hospitals. So I think, I think from my standpoint, you'll see a sugaring out of 2 kind of major developments in terms
Geographically driven.
Geographically driven, because you've got to be linking yourself to something bigger, because you want to get to a population base that makes sense financially. And for us, 45,000 people is not that number.
Which is a great segue, Steve, to our next slide, which is the Vermont payment reform efforts. And it is fair to say that New Hampshire really isn't playing in the federal Affordable Care Act arena.
You want to pretend it's going away.
Yes.
Right.
In fact, New Hampshire did 3 things, and I think they're great. They did it 2 years ago, so they didn't do it this year. But 2 years ago, they did 3 things. The legislature ordered the governor to sue the federal government, as if the legislature can order the executive branch to do something. That's a great constitutional issue there. They also passed a law that said, notwithstanding any law that the federal government passes, no New Hampshire person shall ever have to buy health insurance. Another great constitutional issue. I think we fought wars over that particular one. And then they also said to their insurance commissioner, we don't want that dirty money. So whatever money you got to implement the health benefit exchange, return it to the federal government. We don't need it. Vermont has taken a dramatically different approach. So here's and Richard Slusky can talk about this, the director of payment reform in Vermont, far, far, far better than I can. But there are 3 kind of current models for payment reform in Vermont. There's a bundled payment model, and hospitals are participating in that. Hospital physician budgeting models, and then population-based global payment, hopefully soon. But I think the bundled payment's probably the one that has the most momentum right now. But Vermont administrators should be on notice that the Green Mountain Care Board is not hiding the ball. They are not being sneaky about what they want to do. This is what they want to do. This is from the Green Mountain Care Board annual report. All roads lead to Rome here. And Rome is population-based payments. That even if it starts as a bundled payment, it's going to move to a population-based payment. Even if it starts as a hospital physician budget, it's going to move to a population-based payment. That is the mechanism by which the state of Vermont wants to move its payment reform. Probably not in the interim step of the health benefit exchange, possibly somewhat in that interim step, but more so with the implementation of Green Mountain Care.
Significant problems with doing that. There's a lot of
Sure.
linkage of people across the borders, employees, employers. That's going to be really hard to wrap themselves around that.
Yeah.
And
How many?
small numbers.
How many folks do you serve who are not from Vermont?
40%.
40%. Wow. So if you got paid on a population-based payment,
We'll be talking to a lot of ACOs.
yeah, and so you could get paid for your Vermont folks, but you're still going to have to keep your other payment systems for folks from Massachusetts or New Hampshire, or New York, or wherever, because Vermont's not going to pay for them, and they're probably not going to pay you either. Those states aren't going to pay you either.
Well, that all depends on how.
On a population-based system.
Yes.
Yeah.
It all depends too in psychiatry how many hospitals stay in the game of running psychiatric units in a bundled payment system, where the incentives will probably be very low and difficult to manage it appropriately. They may just decide we're not going to run that psych unit. I don't know.
Yeah.
We'll have to see. All depends on the incentives created.
Okay. What's going to happen with the federal reform? Now, not all of this goes away if the federal reform law, the PACA, or the Affordable Care Act, derisively Obamacare, goes away. And the Supreme Court right now has 4 questions in front of it. I'll go through them quickly. One is the expansion of Medicaid constitutional? And in Vermont, we didn't much expand our Medicaid. I'm not sure. New Hampshire, was the New Hampshire Medicaid at 138% of poverty prior to the Affordable Care Act? At least that, yeah. So there was no expansion in Medicaid in Vermont, in New Hampshire Medicaid either. In fact, some programs in Vermont under our global payment system that we have are, what do they call that? Is it not the, is it the contract we have with Medicaid to cover Medicaid patients, and they give the state of Vermont a single global payment. Is it called global payment?
You're talking about federal?
Yeah.
Global payments.
Yeah. In Vermont, there are some programs, Dr. Dinosaur, I believe, that goes up to 400% of the poverty level will cover kids. In some states, you could be at, so the federal government said Medicaid has to be at 138% of poverty. It can be higher if you want, but at least 138% of poverty. And if I bashed on New Hampshire earlier, I really bashed on Alabama and Mississippi because those states had poverty that had Medicaid levels far below 100% of Medicaid. You could make 70% of the federal poverty level and you wouldn't be eligible for Medicaid in those states. And the federal government said, oh, come on, guys. You got to do it, 138%. And then they pretty much paid for all the new people who were added into the system. But those states said, even though you're paying for it, we think it's offensive and we think it's a violation of the federalism and we are going to sue you. And nobody really thinks they're going to win. But they made the case. This one has a chance of being overturned, and that is the individual mandate constitutional? And so in the federal health care reform law, there is a mandate, thou shalt have health insurance. Everybody, January 1, 2014, you will have to have health insurance. And if you don't, there's going to be a penalty come April 15th, 2015 on your tax return. And that, according to 26 states that are suing the federal government, is a violation of the Commerce Clause. That the federal government, which is a government of enumerated and limited powers, does not have the ability to tell you that you need to have health insurance. But Massachusetts did it, right? I mean, Massachusetts has a mandate, and states can do it. And you know, you can bet your bottom dollar that if federal government if the federal law, if the Affordable Care Act is overturned, the state of Vermont, if it thinks it's necessary, would pass a mandate that everybody have health insurance, if that's an important element of their reform. Yeah, yeah. It's not controversial for states to do it, but not really controversial. But it is pretty controversial for the federal government, and nobody knows how that's going to turn out.
Although all those other countries you had up there on the first slide
yeah.
have done that.
Have mandatory health insurance. Yeah. And then the question, one of the other questions that's going to be asked or answered is the individual mandate severable? Can we just throw away a little bit of the Affordable Care Act, or does the whole thing go away? And if the whole thing goes away, CMS and the Center for Medicare and Medicaid Innovation, they still have some ability to fund certain programs. Now, they'll have the regulatory power to do it. Whether they get the funding from Congress to fund these programs is a different question. And then the last one is just for lawyers. It's the Anti-Injunction Act, and usually you can't appeal a tax until the tax has been assessed. But like I said, the tax won't really be assessed until 2015 for failure to have health insurance in 2014. The decision on this is out very soon, probably. I've heard June 25th. I don't know. I didn't think the U.S. Supreme Court told everybody what day they were releasing the opinion, but I got an email blast that said, watch for it, June 25th. Maybe that's a little inside information for you. And nobody knows what's going to happen. And if the range of things that could happen are incredible. If the entire act is thrown out, every state in the union, including Vermont, really starts at about step one again for its healthcare reform efforts. If it doesn't get thrown out and it's upheld in its entirety, many states are going to start to scramble, I assume, to implement a health benefit exchange as of January 1, 2014, because nothing would bother New Hampshire more than having the federal government implement the exchange in New Hampshire. Like, that would just be awful. Have those feds coming in with, like, there'd be guns on the border. Yeah, right. I think you allow guns in the State House already. They'd be shooting the guns in the State House this time. But that's if it survives, everyone will have to have a health benefit exchange as of January 1, 2014, including those states that didn't want to do it. Okay. Here's and I'll go through this quickly. The federal reform, Vermont has taken the Affordable Care Act and pushed it out to the furthest reaches it can in order to make the health benefit exchange kind of an interim step between where we are now and Green Mountain Care, which would be universal health care coverage. And Vermont has said, no other state, I don't think any other state, no other state has said that the only place you will be able to buy health insurance January 1, 2014, if you're in the small group market, that's 50 employers or fewer now, and it'll be 100 employees and fewer at 2016, January 1, 2016, is on the exchange. There will be no health insurance market outside the exchange. Now, that freaks some people out. It freaks a lot of the employers out. But in reality, it's not that much of a difference because we only have 3 insurers and 2.5 insurers really now. So it's not going to be a reduction in the amount of insurers. And it's probably not even going to really be a reduction in the amount of insurance options available to individuals. It is going to, I'm a member of the Brattleboro Area Chamber of Commerce. It's going to freak out the Chambers of Commerce and other association plans, which is a way that small group employers got to act like big group employers, large group employers. Those are going to go away. And so the small group is going to be the only, if you're in the individual or small group market, you're going to have to buy from the exchange. Okay, the state of Vermont really wants you to be in the individual market. And so they're going to collapse the individual and small group markets into a same rating group. And that's going to, that just, it's more expensive in the individual market now. It's almost cost prohibitive in the individual market now. So by collapsing them, they'll bring down the cost of the individual market. I don't know, maybe the small group market goes up a bit. And they optimistically think that large group employers who want to come into the exchange will do that in 2017. Okay, why does the state of Vermont want this? And why does the state of Vermont really, really, really want the Affordable Care Act not to be overturned, at least certain portions of it? Is that individual federal tax credits are available only through the exchange and only if employees purchase individual, not employer-sponsored product. So those tax credits, you do not get them if your employer sponsors a health plan for you. You get you get the insurance your employer sponsors, and you're going to have to pay some, probably what you pay now, but you don't get the federal tax incentive. And the state of Vermont wants to, in an interim step, decouple health insurance from employment with this particular provision. And tax subsidies, or tax subsidiaries, I'm not sure what that means. It's a fancy word that's used incorrectly. Tax subsidies are phased out at 400. Drew, I asked you to prove that. Tax subsidies phase out at 400% of the poverty level. That's for a family of 4, it's $92,000. That is well above the median family income in Vermont, which is like $55,000. If you go, there's a great website. I always mean to put it on here. I never do. If you go to Kaiser Family Foundation, website, you can put in, a median family income, and it will tell you how much money in the individual market with the federal tax subsidies that are subsidiaries that are already described, how much people would pay. I did it $50,000. I said, family of four, $50,000. How much would that family of four pay if they had to buy their health insurance on the individual market? Any guesses? When January 1, 2014, when the Affordable Care Act goes live. I'll tell you what the insurance, they assumed that the insurance would cost $13,000 a year. The family of four who made $50,000 would pay $2,000. There'd be an $11,000 tax incentive for you to buy it on the individual exchange. That is why the House Ways and Means Committee thinks, because it asked the Fortune 500 companies, 75% of the Fortune 500 companies said, we will no longer provide health insurance to our employees. It doesn't make any sense. It doesn't make any economic sense for the employer to do it, and it doesn't make any economic sense for the employee to do it either. It's better for most folks under this system to go get their health insurance off the individual exchange, and that's what the state of Vermont is banking on, but that's why they need the Affordable Care Act to survive. Okay. All right, Green Mountain Care. Now, back to you guys. What happens if I move to the state of Vermont, and it's residency, not citizenship. I'm a citizen of the United States. I'm a resident of Vermont. I can come and go as I want. And I come and I establish residency. What's going to happen to your businesses, and how are you going to have to adjust if I have in my card my Green Mountain Care card that says I get health insurance as a right in the state of Vermont?
There is no answer yet.
We have 20 minutes. There got to be some answer. How about like a 4-minute
There are a
answer?
lot more questions
Yeah?
than answers in front of this Green Mountain Care Board. And, I think the one thing that they're focused on is obviously a population-based methodology for managing and financing healthcare.
Mm-hmm.
But other than that, payroll tax?
Well, we'll know January 2000. Some people point out that it is immediately after an election. January 15, 2013, we'll know the administration's proposal, or at least the report back from the Department of the Administration, the Agency of Administration to the legislature.
We need the tax credits, and we don't have.
Huh?
They can't fly without it.
Vermont's depending on the federal government.
Right?
Question for you.
Yes.
What if I've got my little card, I'm in Vermont, and I say, you know what, I don't think I can get the health care I need in Vermont. I think I need to go to Boston Children's Hospital. Who pays for that?
Well, it's probably not dissimilar to the situation you and I are in right now. And instead of picking up the phone and calling Blue Cross and Blue Shield to see if that's in network and can you get it covered, and do they have an agreement with Boston Children's, and or is there a copay out of network and those kinds of things, you'd call, I assume, someone at the state of Vermont or someone who is administering the program for the state of Vermont, which might be Blue Cross Blue Shield, right? I mean, they're already half the state anyway. They just get twice as big. That's a piece of cake. But the state of Vermont, in that way, would have to be your insurer, and then would have to enter into contracts with the out-of-network providers, unless they think there's enough utilization, enough capacity in the system to deal with those situations. But I think that that's probably not true, right? I mean, Vermont isn't such a well-developed health market that we would have every capacity.
No, you'd have to go to some, especially tertiary, some services.
Yeah. So, Don, would you'd be negotiating with the state of Vermont rather than Blue Cross Blue Shield?
So what Dartmouth does, because especially in Dartmouth Medical Center, Mary Hitchcock, there's a lot of people who cross over and get their routine care there because it's much closer to go to Mary Hitchcock than it is to go to Fletcher Allen. They've looked to get this border provider status. If they have the border provider status, people can come across to New Hampshire. So I guess in a sense it's part of that network. Keene is not part of that. And so that,
Oh, no?
so they're very selective in terms of who they give that status to.
And that's a board, I'm sorry, you may have said it, border provider status from the payor, from the insurer? And they don't consider Keene to be a border town.
Right, because when they negotiated, they just really negotiated Mary Hitchcock because they felt that would be the easiest thing to get through. And so despite the fact that a lot of people do come to Keene for some of the things that they might normally have to go up to Lebanon for, technically they can't. We see them, we don't get paid. That's what happens.
And did you say that 40% of the people who are treated at Dartmouth Hitchcock are across the state from New Vermont? What percentage are folks from Vermont who are treated at Dartmouth Hitchcock? Yeah.
You've heard that 40%. Yeah, mentioned 40%.
Yeah. So in a way, you know, Dartmouth Hitchcock's kind of in the catbird seat. You're just outside of the regulatory reach of the state of Vermont, but you provide care to a lot of Vermonters.
But they don't have to pay. Vermont doesn't have to pay Mary Hitchcock. Patients go there.
Yeah.
So that's the part where they have to make sure they get paid, just they'll provide the care.
All states do that. They pay the out-of-state providers less than they pay the in-state providers. Mass basically doesn't pay anything more than
Really?
New Hampshire pays Vermont less than they pay New Hampshire, and Vermont pays New Hampshire and Mass less than they pay the in-state providers.
All evens out.
It's like poking each other in the eye.
In New York, forget about it.
Yeah.
20% of bill.
When I give this presentation to employers, they freak out. They freak out at Green Mountain Care. And part of the reason they freak out is because it's you know, I keep using the expression, I'm hoping it's going to catch on, it hasn't yet, that universal health care coverage is difficult to implement without a Navy, without controlling your border, without having all of this cross-border movement. And I mean, that's not a criticism of the Green Mountain Care Board. It's not a criticism of Green Mountain Care. It's just a reality of the federal system that we live in, where we have this free movement between the states and among the states. And so my employers, every single time, I've done this 20 times, every single time somebody says, well, the greatest proponent of Green Mountain Care in Vermont is going to be a New Hampshire employer on the border. Because every morning, all of that employer's employees are going to wake up in Vermont with that Green Mountain Care Board, you know, that Green Mountain Care card in their pocket, and they're going to come across the border, and they're going to bring with them all that health care. And that's going to be a competitive advantage for those employers versus these employers, because these employers can be taxed by the federal, by the state of Vermont. Those employers can't. So those cross-border issues are thorny, and the Green Mountain Care Board and the administration acknowledge that they haven't figured them out yet. But they are going to be very important if we move past the exchange. So, you know, we don't get to the exchange unless the Affordable Care Act survives. We don't get to Green Mountain Care unless we solve these rather thorny kind of cross-border issues. Yes?
Penalties set up for these large businesses for not providing care kind of offset the hope that people will go to the individual market? Isn't that kind of stuff for that?
That's a great question. Perfect question. In fact, the Affordable Care Act says if you have 50 or fewer employees, and that doesn't go up to 100. Remember I said the small group goes from 50 to 100. The 50 that I'm talking about stays at 50. If you have 50 or fewer employees, you cannot, either by the federal government or the state government, be penalized for failing to provide health insurance to your employees. Now, the state of Vermont currently has a, if you don't provide health insurance to your employees and they participate in a state health care program, that you as an employer have to pay. You will not have that as a small group, a 50 or fewer. But remember, the poll that, or the survey that the House Ways and Means Committee sent out didn't ask 50 small group employers with 50 or fewer, and they didn't ask 100 or fewer. They asked Fortune 500 companies, what would you do? And they all said, or 75% of them said, we'll cancel our health insurance for our employees, because the penalty for them is $2,000 per employee. And so they think, even with the $2,000 penalty, it makes economic sense. Or, you know, if the House Ways and Means Committee is to be trusted, which is, you know, a debate. But if the House Ways and Means Committee is to be trusted, then even large group employers will cancel their insurance. Even in those largest 500, the Fortune 500 companies, none of them provide health insurance to their employees. I'm pretty sure they're all ERISA plans. They're all self-insured. They're not kind of the way everybody else has health insurance. They are large enough that they're self-insured. They'll cancel their self-insured plans too, or at least 75% of them will. We're getting close to 7, and I am done with my slides. So I want to give you guys an opportunity to, if you have any closing thoughts and comments about federal healthcare reform, state healthcare reform, what it's like to be a hospital administrator these days, and challenges you have in front of you.
You're looking at me?
Yes, you.
You know, I think, forgetting about for a moment up in Montpelier or in Washington, we're going through a real paradigm shift locally with our physicians, which, as I mentioned before, we're moving more towards that employment model. We now have all of our inpatient admissions being cared for by hospitalists, not by the primary care physicians. So it's a whole new specialty now that has developed. We're looking at having to make some substantial capital improvements in the hospital, especially with an upcoming emergency department. So we have a lot of pressures on us, both from that the physicians are going through, and as mentioned and Don mentioned as well, new docs coming out. We've got to be able to recruit the physicians that are now retiring. We have to have a viable model to recruit and manage those practices. And for us, it's cost over $1 million right now for that new system. So huge number of pressures, huge number of changes just in our own Brattleboro system of care here. You layer all of that on top of getting paid less. We're not going to get paid anymore, we all know that. But now getting paid less and the pressure's being pushed down. And I think one of my biggest concerns about Green Mountain Care Board and kind of Vermont's approach is that there's a lot of utilization that can be driven out of the system and saved, to go to these kinds of programs. And I'm very concerned in our area here that I don't see that much excess utilization of our services in Brattleboro. And that's been shown actually within the state's own studies and statistics that in Windham County and in Brattleboro, we have the lowest utilization within the state of Vermont for healthcare services. We don't have that big margin where you can start ratcheting down care. I think we're pretty close. I'm somewhat concerned that sometimes we don't have enough utilization for some screening mammographies, things of that nature. That has me more concerned as well. So I'm nervous as this all plays out, and also is playing out in Montpelier. They look at the southern part of the state as kind of a little bit of a different area, maybe part of New Hampshire, part of Massachusetts. So I've spent a lot of my time educating our legislative delegation about the pressures that are here in the southern part of the state and part of Brattleboro in particular, because it is going to be a political agenda up in Montpelier as we look at a new system of care for the state.
Thank you. Rob?
Well, on the retreat side, the last 3 years, the retreat has gone from a hospital of filling about 50 beds to a hospital that's filling 100 beds every day. And also with ambulatory services, partial hospital, outpatient services, residential care for children. With the Children's Hospital for the state, recently we've become a player in the state hospital for adults in the state. So what clearly worries me is as our hospital has grown and been a tertiary care environment for specialty care for psychiatry and addiction, that people come across borders, that they look for specialty care. We provide some niche services. We provide the only LGBT inpatient psychiatric unit in the East Coast. We provide specialty services for uniformed service workers, policemen, firemen, veterans who leave their states, 20 to 25 states. People come to the retreat for that. What will happen when we create ACOs and people will be limited in where they can go? I worry about that for the retreat's future. At the same time, as a citizen of this country, I believe we can't afford that curve that you showed in your first slide. I completely agree about that. And it's not right to have so many people who get their care in emergency rooms, who wait for preventative care, who wait to the last minute and the disease has moved on to a high cost. Sometimes costs something that can't be fixed and waited so long. I worry when our children now, between the years of 18 and 26, when they graduate from college, now they're covered under Obamacare. They have insurance. Did I have insurance when I was 22, 23, 24? I didn't have it. I would never have paid for it, unless I had a job that the employer paid for it. And I worry about young people who may have the beginning signs of illness, particularly psychiatric illness, which comes in their 20s. If they're not covered by insurance, then they're in a system that is very unsure of them for them in the future. I worry a lot about that. So I like the trends where the retreat has gone, our growth, et cetera, but there are a lot of risks on the horizon. I think Vermont's too small to carry the risk in this idea. I think we have to have full service account Obamacare to make it really work. All the tax incentives to be lined up. So I'm really looking forward to June 25th.
John?
So one of the things we talk about is sustainability. And in Dartmouth, we know, and I think all of us here know, that the healthcare system, the way it's set up right now, is unsustainable. The problem is I don't think the population in general in the country knows that healthcare is unsustainable, and that the population just wants more. And from my perspective, the way we get reimbursed drives the concepts that cause us to have this unsustainable approach. Really, fee-for-service just drives more care. When we can't pay our bills, we just do more. As a physician, if you cut how you pay me for that specific unit, I'm going to do more units. And we all do that. It's just the wrong approach to healthcare, and it really drives that unsustainable model. So what Medicare will do is they'll say 2% across the board, everybody gets cut. Well, you know what, in Texas, in Florida, they probably can afford a 2% cut in terms of how Medicare gets paid, because they get paid at a much higher rate than we do in the Northeast. That 2% will affect us here in Vermont and New Hampshire so much more than the rest of the country. And so for us, really the answer, the burning platform is consumer. You know, we have to change. We have to change into a different model of care. Is ACO the right model? I don't know if it's the right model, but we have to move from a fee-for-service widget approach to just driving volume into some kind of value-based approach. And that people who are out there who begin to understand this might start to think about, what really should my health care be? Because I can't afford $10,000, $20,000 for that health care premium. And that I'm not getting the outcomes that I should be getting, because people come into me all the time and say, well, I have Cadillac insurance, just do all the tests. Well, forget about the downside of doing all those tests in terms of the bad outcomes or the things we do to you that are iatrogenic. But really, the dollars it drives, it's just unsustainable. And we have to begin to have the rest of the population look at this, understand where we are, and not just say, well, I'll just, it's okay, I have insurance. And that's the problem for our country.
Thank you. Thank you, John.
Thank you.
Thank you, everyone.
Thank you, everybody. They're refreshments outside.